I've got all sorts coming up on the screen. Okay. May I welcome members and the viewing public to this briefing of members of the council being conducted remotely, and may I wish you all a happy new year. Please can I have your attention whilst I have to make a few announcements about how this meeting will be conducted. This briefing meeting is being conducted using Zoom as a virtual platform and will be live streamed for the public to view via the council's Public Eye webcast site. This will mean that the recording will also be available for people to view later on through the council's website. Because this briefing is being webcast, please can I ask members to keep their cameras turned on for the duration of this meeting. To help make this meeting run as smoothly as possible, it is important that participants in the virtual meeting room have their microphone on mute for the duration of the meeting. Please only unmute when you are invited to speak. This will help reduce the scope for noise and interference. May I also ask that all mobile phones and similar devices are all turned to silent in order to remove any potential disturbance when speaking at the meeting. Thank you in advance for your cooperation with this. I need to remind members that the guidance provided to them earlier in the week by Paul Robinson from Direct Democratic Services, that if you wish to speak at the meeting, you should use the Zoom chat facility to request to speak. It's important that you use the message send to everyone and not directly to himself. Officers will be monitoring the chat on my behalf, and messages sent directly to me run the risk of you being overlooked. Please don't use the chat facility for any other purpose. Again, thank you in advance for your cooperation. Before moving to the main item of business on the agenda for today's meeting, I wish to say a few words regarding the cancellation of the formal meeting of the council, which was scheduled to be held today. In the 2020 governance, the government introduced a temporary regulation permitting local authorities to hold their meetings remotely. Those temporary regulations ended in early May 2021 and have not been extended. Without a change being made to the law, local authority meetings have to be conducted in person in order to be properly convened. Following the Omicron variant outbreak and the recipients of advice from the Office for the Director of Public Health, the need for meetings scheduled for the remainder of December and early January was reviewed by the corporate members group in order to minimise in-person contact. The group included all the leaders of the political groups on the council. As a result, it was agreed that the formal decision-making council meeting scheduled for today would be cancelled and that an online video conference be held in its place in public to enable the Director of Public Health of Sheffield to provide an update on COVID. The update on COVID was to have would have been one of the two main items of business for the January meeting. Of the two decisions which had been scheduled to be taken at that meeting, one has been deferred to the next council meeting and the other has been taken by the Chief Exec using emergency powers with the approval of the political group leaders. The other main item of business which was to have been considered at the meeting was petitions and public questions. Because this meeting has been convened in accordance with the provision of Local Government Act 1972, questions and petitions from the public will not be taken at this briefing. Members of the public who want to present petitions or ask questions at the January Council meeting will be given the opportunity to do so at the next meeting on Wednesday, the 2nd of February. Alternatively, petitions can be presented and questions can be asked at the meeting of the Corporate Operative Executive on the 19th, Wednesday, the 19th of January. The Council meeting for February and March, which will have to be held in person, will now be held at the Ponds Forge International Sports Centre to ensure safe working practice for all our council members and officers and members of the public. I shall now move to the main focus of today's meeting to receive a presentation from Greg Fell, the Director of Sheffield's Public Health, providing a briefing on the current situation regarding COVID-19 pandemic. Greg is accompanied today by Anthony Gore, a GP at a practice in the city and a clinical director for children and young people and maternity at the NHS Sheffield Clinical Commissioning Group. This will be followed by the opportunity for members of the council to ask questions. If members wish to speak and ask a question, may I remind them that they need to request so on the Zoom chat using the facility a message to everyone and not directly to myself. To assist me to manage this process, it would be appreciated if you could also specifically tell us the topic of the question that you wish to ask. This will assist me to manage this process. I will invite members to ask their questions and I may group questions accordingly to the topic and take perhaps 2 or 3 questions at a time. Greg and Anthony will be responding, but answers may have to be provided later in writing if they can't fully answer your questions. Thank you for that, for listening to that long brief, colleagues. I'm now going to hand over to Greg Fell.
Thanks, Lord Mayor. The Lord Mayor's done an introduction of Anthony, so I won't repeat that. I believe you've had the set of slides I'm going to talk to, so I'm going to talk to them reasonably quickly. Aim to talk for about 10 minutes. I'll then hand over to Anthony to add in any particularly important bits that I left off, and then, as Lord Mayor says, open for questions. So with no further ado, I shall screen share. Someone shout to tell me you can see that okay. Yeah, thank you. So 2 years in and counting, we all want this to be over. It's patently apparent that it's not over yet. I'll talk for about 10 minutes of these slides, a bit of an overview of the core concerns, a bit of an overview of the epidemiology as it is of today, impact of the epidemiology, the vaccination program, which is clearly still really rather important, and some thoughts on the strategy now and then going forward, and all in 10 minutes. Key concerns now. The case rate is extremely high, by orders of magnitude higher than we've seen at any point in the whole of the pandemic. I shall come on to the specifics in a minute. Case numbers are high, but harm is low in young people, children and young people. Case numbers are high, and there are a non-trivial number of admissions in 18 to 55-year-olds. In fact, no, non-trivial underplays that. A significant number of admissions in 18 to 55-year-olds, and the case rate is increasing in over 65s, which have always been the group I've been most worried about. Perhaps less so now, because the over 65s are a very well vaccinated and boosted group of people. So perhaps less so, but still, case rates are going up in the over 65s, and that is still a concern. A large spike in admissions, perhaps stabilising a little bit, but number of people on respiratory report remains high. And I would say at the outset, a lot of the media and public narrative is about what's happening in hospitals. Omicron would appear to be creating a lower acuity illness in people, i.e. there is some truth in the it's milder. I shall come on to the caveats on that in a second, but that also means a significant number of people are poorly enough to present to primary care. The pressures in primary care and social care are just as unsustainable as the pressures within the hospital, and that is a big deal, and it's really important. So I'll come on to that. Steady state, steady reports of deaths in hospital, but really very low. Certainly not in the anywhere like the same places they have been in previous waves. Vaccination program all up is going exceptionally well. But vaccination uptake in 12 to 15-year-olds is slow. But more of a concern for me is the 100,000 plus unvaccinated adults. That's by a long way my most pressing concern of the moment. So epidemiology, this is from the course of the whole pandemic. This was the initial wave, and this is the case rate. It didn't get very high. This was the autumn 2020 spike. This was the alpha spike. This was the delta spike, which just for most of the spring, summer, autumn, trundled along at a case rate of about 250 to 300 per 100,000 over the 7-day period. Omicron struck. The numbers you can see are perfectly apparent. It invented a whole new meaning to the word exponential growth. And currently we're hovering at about 1,800 cases per 100,000 population in a 7-day period. Give you some example of what that looks like in numbers. I think this was the last full week for which I've got testing data. About 20,000 people, more than 20,000 people got a PCR test, of which there were more than 10,000 people tested positive, more than 10,000 cases. Numbers hugely above what we've ever seen for any. The graph is apparent any point in a pandemic thus far. The all-time chart looks like this. So this is all cases, the grey bar. Hospitalizations, the blue line, and you can see here hospitalization rate when case rate was much higher here. Deaths are really not there now, and the two green lines are vaccination dose 1, vaccination dose 2, and boosters. Note this little blip here just before Christmas, and I shall come on to that little blip because that little blip has saved many lives. That little blip isn't isolated to Sheffield. It happened certainly across England, probably across the whole of the UK, but that blip matters. So, but what we're seeing is that given our case rates currently, which are way off the chart up here, nearly on a new chart, the hospitalization rate is certainly nowhere near as high as it would have been had we not had a pretty high level of vaccine coverage, aka despite my worries in November, early December onwards, when Omicron first emerged, there was a potential that there was significant vaccine escape. The vaccine is still protecting us from serious illness to a very high level, and it has done the job that it promised, and I think we'd all be thankful for that. Age bands. Currently, the epidemiology is that the age-specific case rate is going up in all age groups, principally early on in the Omicron wave, driven by early working age, but it's going up in all age groups at the moment, and perhaps beginning to stabilize a bit, but difficult to draw too many definitive conclusions to that because there have been, and just about still are, but it's easing, significant issues with regard to access to PCRs because there were so many people poorly seeking tests. Lab capacity was a big national problem. So interpreting the case rate data is actually quite more difficult than you would imagine, but perhaps some signs that the case rate split by age band and across the whole population is beginning to stabilize a bit. That again probably has happened in London. London's a couple of weeks ahead of us. So some signs that the wave will be relatively short, but the consequent knock-on impacts may not be so short, and I'll come on to that. Where Sheffield looks in comparison to the whole of the country, for the geographically challenged of you, Sheffield is there. So mid-table, for want of a better phrase. Obviously, it's much higher rates in the northwest of the country, slightly higher rates in most of the rest of Yorkshire, certainly South Yorkshire. But these are, any way you cut it, the rates that we've got, the numbers that we've got are hugely more than we've ever seen at any point. So there's, just because we're mid-table, that doesn't mean we're in a comfortable position here. Even in the southwest of England, those rates are still very high. But that's the look and feel of the epidemiology nationally. Vaccine coverage, the numbers are too small to see on the chart, but all up, 70% of people who are eligible for a booster have had 1 dose, 2 dose, and booster. And Sheffield is still the leading of the core cities, I think, on just about any cut of the data, and any way you cut it by age and or by other means. Sheffield is still the leading of the core cities, but you can see, 77% fully vaxxed plus booster means 23% not. So there's still 100,000 odd people who are adults who haven't yet had any vaccine at all, and that is a concern for me. Hard to know what we could be doing that we aren't doing, to be fair. Lots of people will have made an informed choice not to be vaccinated. It is a medical intervention. People should make an informed decision. I frequently remind people to test the information base upon which they've made the informed bit of that informed choice. But I think it should be assured that as a city we are doing all we possibly can. Always keen to hear new ideas, but I think it's just a struggle to think of things that we could be doing. There is an age cohort difference. So if you split it by age, the 80 plus, dose 1, dose 2 plus booster vaccination coverage is well north of 90%, probably closer to 95%. But if you look at the 18 to 25 group, it's probably closer to 50%. So yeah, the level of vaccine protection comes down as you come through the ages. But most important message from that is that those are most likely to be made seriously poorly. Remember, this is a very, very, very age-driven disease. That group are the best protected. Sadly, there are still geographic and ethnic differences. East-west split, we've talked about that before, and a black-white Asian split also. Again, done a lot of work with and through community and faith leaders and making the vaccination as accessible as possible. So that whilst there is a split, one, it's not a bigger split as I'd feared it might be, and two, like for the general populations, it's actually hard to know what we could be doing that we aren't doing, but that work continues. Now, remember this blip here, when Omicron broke out in mid-December, the available science at that time was very clear that 2 doses wasn't enough. 2 doses plus booster and the immune response that would give would almost certainly have been enough, and there was a measured bet that would be enough. Hence, the Chief Medical Officer making recommendations to the Prime Minister, we need to accelerate the booster program. So the booster program had been running since October 21, a really quite rapid rate actually. Had been going really, really quickly, but the call in the 2 weeks running up to Christmas and the week between Christmas and New Year, and this is still going on, was accelerate the booster, please. This is the number of doses given per day over in the period in the run up to Christmas, and that's exponential growth. The effort to make that massive jump in the number of boosters given was unprecedented, and credit to all those who made that happen, because it definitely didn't happen by magic. It happened because a lot of people gave a lot of time and worked between Christmas and New Year and worked nearly all the hours God sends to make that happen. That will have undoubtedly saved lives and spared lots of people from very, very serious illness. So I think I'm particularly thankful for the efforts put in by many, particularly the NHS, but also many local authority employees and many people who are community and faith leaders and work in community voluntary sector organisations. They collectively made that happen, and that does matter, really, really matter. So that little blip in the chart there actually looks like that, and that's a huge growth in the acceleration of the booster program. Not peculiar to Sheffield, it happened everywhere up and down the country, but I'm talking about Sheffield here, and that did make a difference. 10 things that concern me today. Testing, been a huge problem over the Christmas and New Year period. Massive spike in the number of people poorly, massive spike in demand for both lateral flow device tests and primary care PCR tests. That is beginning to ease. I don't think we're quite out of the woods yet, and it's quite fragile. but the logistics and the supply chain were one of the rate limiting steps, particularly with regard to lateral flow device tests, and the lab capacity was the other one, which was obviously particularly pertinent to PCRs. And that's beginning to ease, but there were significant problems over Christmas and New Year period and into the new year. And I'm not clear on what the government long-term strategy with regard to testing is, and that's an ask of the next couple of weeks to couple of months of government. Our support to the vaccination programme remains undimmed and will remain undimmed until the bitter end. You'll be aware that it's funded through the Contain Outbreak Management Fund, which is a fund made available by government to local authorities to support all aspects of the COVID response. The one that we would support until the bitter end, until there is zero money left in the comp grant, would be the support to the vaccination programme. Impact of the virus. It is a massive issue at the moment. The business continuity of many services, where in a context with very, very high case rates, is a big deal. We know that very publicly reported on for NHS and social care, but anyone running a business, they're going to have people off poorly, and they're going to have people at home isolating. That's going to be a problem, and that will be something that we'll need to deal with for probably the next month or so. That plays out with regard to schools. Government and me, for what it's worth, I'm absolutely clear that face-to-face education is very, very important, and education has been disrupted, and that will have consequences that we'll deal with in years to come. But high case rates mean a lot of kids off poorly, will mean a lot of teachers off poorly, and that will come with some disruption to school. Unsustainable pressure on NHS and social care, and I unashamedly add in NHS and social care, and by NHS I also mean primary care. I've talked about that a lot. The pressure in all bits of the NHS and all bits of social care on account of the managing the illness caused by COVID is significant, with less staff, and that inevitably will have consequences in terms of delayed care, and that will come with consequences. Again, most obviously access to elective care and waiting lists, but any aspect of any healthcare, people's care is being delayed. There's a steepening rise in the over 65 population with COVID, and that is a concern. I've talked about that, so I won't dwell on that anymore. Ditto the 100,000 people plus who aren't vaccinated, about 22% of people aged 12 or more in Sheffield. Care homes, there are lots of cases at the moment, significant number of homes with outbreaks. Omicron is spectacularly transmissible. It's going to get everywhere. Not as much harm by a long stretch as we've seen in previous waves. It's a very, very well boosted population. So we're seeing lots of people with really very mild illness, very few but not no hospitalizations. So not as much harm as we have seen. And coverage of the booster in the care sector, in employees in the care sector, is a thing that we will keep coming back to because there's more to do there. Sheffield isn't London. Sheffield is about 2 weeks behind London, there or thereabouts, but it's not London. The population is different. The shape and timing and nature of the curve is different. So probably the worst was done in London by the time Christmas arrived. We had Christmas to add into that, and that will have an impact for us. And the shape and nature of healthcare services in London versus Sheffield is a little bit different. Sheffield is well served by excellent healthcare, as is the whole of the country, to be honest. But what would concern me more is a very, very rural area with longer geographic access to healthcare. The future, nearly done. Very unpredictable. We all want normal back. I want normal back. I'm bluntly sick of COVID. However, I don't get to decide when that happens, sadly. So there'll be the when does normal return will be a judgment made on the basis of the impact of the virus. Population immunity rates will play a big part in that, because that's significantly reducing the impact of the virus versus an artificially imposed endpoint. And sadly for all of us, I think we will be in some form of adaptation and or living with, and quite what that means requires perhaps a little bit of definition. We may discuss that in just a second. Last two slides. Why should I bother? This is a mild illness. It is a mild illness. Milder does not mean mild. it's still hospitalizing hundreds of people a week. And those that don't get hospitalized, there are still plenty of people who are really, really poorly, actually. Long COVID is a concern, has been a concern of mine throughout. The case rates at the moment will be creating more long COVID. That's a disability that will have a bearing on, obviously, NHS and social care demand, but will also have an impact on sort of economic productivity, people's ability to work. And that will be unequally spread, sadly. It might be mild for you, but the chains of transmission and protecting vulnerable remains important. So those are the individual reasons why I should bother. The wider reasons: hospitals and the NHS and social care system are exceptionally busy. Many hospitals have declared black alerts. That has consequence in terms of delayed and displaced care. With that will come with consequence that we will deal with in the months and years to come. Business continuity. If services are closing, then we're just going to not have services available if places are closed because all of the staff are isolating. And obviously, I've said it before, I'll say it again, the more cases there are, the more chance there is for variants. Omicron, all of the variants have been significantly more impactful than the original Wuhan strain. Obviously, what's changed is the availability of vaccination, but Omicron has had a significant impact. Imagine where you've got a scenario which is significantly more transmissible and significantly more pathogenic and significant vaccine escape. And we've had vaccine escape with Omicron. We might have with that. We may be in a worse position in the future. Lastly, the government strategy. Our local response is continuing as it always had. And all of the machinery for that is in place. It's all funded by the Contained Outbreak Management Fund, or COMF as we call it, up to the end of the financial year. I do not know what the government's intentions are beyond the end of the financial year. We're beginning to, and I've certainly seen it play out in other parts of the country, staff are leaving. The staff that are running that response, they're leaving because they've got mortgages to pay, mouths to feed, children to feed, etc. So that hasn't yet become an issue for us, but it could become an issue for us soon. So the sooner we get clarity from government, the better on that one. I think the government strategy, for what it's worth, seems unlikely to change. Arguably, it's overly reliant on vaccine alone. I think we should be in a vaccine plus strategy, which we're trying to. But that said, vaccine alone will protect us from severe illness, and has happened. But the number of cases alone is putting unsustainable pressure on the NHS and social care system, not only hospital, as I'll say. High numbers, long COVID I've talked about. Short term, that's going to be, high numbers are going to be business continuity issues, and long term, the long COVID will cause social, economic and NHS and social care issues. All that said, we do need to engineer the exit strategy from COVID, and the exit strategy should be driven by virus harm and the point at which you get an endemic disease which is manageable versus wider needs. There's some conversations to have about risk tolerance. We manage flu as an endemic illness. It still kills 30,000 people in a bad year, but we don't have the same response to flu as we've had for COVID. So there's some societal judgments that need to be made in that space. In the interest of time, Chair, I'm going to stop sharing there and ask Anthony to pick up any critical things that I missed off.
Thanks, Greg. Hello, everybody. I don't want to add too much again for the interest of time, and I've seen Greg's slide in advance. I think I just wanted to reiterate that point at the beginning, that case levels are the highest they have been. The number of people infected at any one time is the highest it has ever been. The number of people being infected every week is still the highest it has ever been. Hospitalization rates remain very high. More than half of those are over 80. And I think that's an important point, because those people are more likely to need aftercare and social care post-admission. And therefore, the impact of COVID on workplace absence in the social care sector becomes huge. It adds to the delayed transfer of care, which means that there are no beds left in the hospital, which affects 999 services, and so on and so on and so on. So it has this so-called milder virus is actually in some ways much more impactful on the services we use every day than the previous versions, just by volume. The high rates of staff absence I just touched on obviously there's been huge high rates of staff absence within the hospitals and within the other healthcare trusts, but it has a much bigger effect on primary care because we're smaller business units. You may only on any given day be using a very small number of receptionists depending on the practice. And actually, if a good chunk of your receptionists are isolating for one reason or another, your ability to answer the phones even becomes hugely impacted. And those are the sort of things, not only that, but also clinical staff being off, that actually impact on people's ability to access care on a day-to-day basis when they're poorly themselves. Having said that, general practice does what it does. It pulls up its socks and tries to struggle on and continues to provide a service on a day-to-day basis. And I just wanted again to reiterate what Greg said about the huge effort in the 2 weeks before Christmas on vaccinations. Everyone really just went into full-on war mode and got everybody working extra days, evenings, weekends, providing these huge vaccination sites that we have working out of each primary care network area. We also have other vaccination sites and mass vaccination sites and walk-in vaccination sites around the city, and pharmacy colleagues doing vaccinations on a daily basis. But the bulk, that big surge, was provided by general practice staff from those vaccination sites in those primary care network hubs. And why? And that's been true throughout the vaccination program. And if I was asked the question, why have we done better at that than perhaps some other areas, I think I would highlight the fact that we had our groups of practices working together for 2 to 3 years as what we called neighbourhoods, as a joint CCG council project, long before the absence of the primary, advent of the primary care network contract that bound those groups of practices together in an NHS contract. And I think that's paid dividends, is that the joint work was there that allowed them to work really, really well together right from the outset. And we set up these very efficient vaccination hubs that have been serving the population. As Greg said, lots and lots of support from charitable sector, from volunteers that have made it all work. And then the only other thing is the unmet need, the population that are not getting vaccinated. As Greg said, it's following socioeconomic and ethnic lines. That's a huge worry. It's exactly the same areas that you see all of on the other deprivation maps that you'd imagine where the vaccination is not as high. We've been targeting those areas from the outset. It's still an issue. And we will not stop. I think we will continue to try and promote vaccination uptake in those areas as best we can all the way through. And then the only other thing I was going to mention about the vaccination uptake post-Christmas as we go through January in the next few weeks, just to highlight that we may well not see high levels of booster vaccination and vaccination uptake through January because people are required to have leave at least 4 weeks following their infection with COVID before they can have their vaccination. That's for adults. It's 3 months for the children, the teenagers. So that will inevitably mean a delay for all that big spike of people who've had it before they can actually have their first, second or booster vaccinations, depending on where they are. So I think that the good work we did before Christmas on vaccination, that was the window. That's when we had to do it. That's the difference that will actually have saved some lives. Now we're into an awkward period where we're trying to mop up, and there's going to be a cohort of people that can't have their vaccination. So we'll just have to be a bit patient on that one. And then finally, long COVID, Greg touched on, massive concern. That many cases, we don't know whether Omicron produces long COVID as well as Alpha and Delta did, but that will produce a huge burden on employment, on the health services, on care, on benefits and so on, if you've got a large numbers of people who are made chronically unwell and unable to work. That's it from me.
Thank you for that, Anthony and Greg. I've got some names. First of all, Councillor Otten, what's your point of order, please?
Thank you, Lord Mayor. It was just that the corporate members group did agree to make this an online video thing, but the point was made, I certainly made the point that we should be taking public questions at this event, and nobody disagreed with that. So I was astonished to see that we weren't going to take public questions as a council at this event. It seems to me that though it may not be compulsory, it's certainly legal for us to do so. And so I just wanted to say it's under protest that we're not that this is just a briefing and not a meeting at which members of the public can put questions to the council.
Thank you,
That was it,
Councillor
thank you.
Orton. Thank you. You were the first to ask a question, so you may do that now.
Oh, thank you, Lord Mayor. Yes, so I remember, Greg, thank you, Greg and Anthony, for your presentation. I remember you coming to the council a little under 2 years ago and explaining to us that, you know, the spread of COVID couldn't be prevented, and the job was going to be, the strategy was going to be to flatten the curve so that, you know, the burden on the NHS at any one point in time was not overwhelming, that people were not dying for lack of care. And at the time, that was the strategy that seemed to be coming from public health people all over the country. And this is before anybody mentioned herd immunity or anything like that. Now, subsequently, obviously, it turned out that the burden would have been much higher on the NHS, and that people would have been dying for lack of care, and that we had to have lockdowns. And
Have you got a question, Councillor?
well, the question is, are we now back to the original plan A from 2 years ago? We're not trying to prevent, we can't prevent the spread of this. We are just slowing it down and flattening the curve. And if that is the strategy, I mean, right or wrong, can Sheffield do anything about that, do anything differently? Is there any point us trying to do anything differently to that strategy? Or do we have to go along with it and embrace it? And therefore, you know, is there a change to what we, apart from the obvious mitigations we should all still be taking, is there a change to what we ought to be doing in terms of accepting a certain amount of contact and a certain amount of, you know, resuming council meetings?
Thank you, Councillor Orton. Greg?
So the difference between then yes is broadly the answer to the question. The difference between then and now is that there's a very, very high degree of vaccine-induced immunity, and the vaccine-induced immunity does seem to induce a stronger immune response. So that's clearly good. That's protected. That has and will continue to protect people. For how long that is remains to be seen, but probably longer than the antibody response people would tell you, and that's because of T cells. The T cell response seems to be quite a long-lasting and durable response. We don't know how this plays out, to be honest, but we've got a scenario where we've got a very good level of immune response. However, we've got a scenario where there's a very, 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 very transmissible virus, as can be perfectly apparent with the case numbers. By the time you find you've got it and get a test and a test result, and then the contact tracers contact you, most of the damage is actually done in terms of onward infection. So I do think we're in a scenario whereby we have all of the basic public health tools, but they are less effective than they were, certainly against Wuhan strain, or whatever we happen to call the Wuhan strain now, and the other variants. So I think we're going to be in a scenario where the effectiveness of the traditional public health tools is less than it was, and but as Anthony and I have both said, the sheer number is putting unsustainable pressure on NHS and social care. That in itself has consequences, never mind the people that are made poorly. So if I had to call it, and this is a guess, to hold me to it in a few months' time, I think the Omicron wave will be a relatively short but very brutal wave, will subside relatively quickly, but the consequences of it will be with us for some time to come. I think we'll have a reasonably quiet spring, summer, possibly early autumn. I've seen plenty of people predict it may all kick off again next winter. So that's broadly about where we are, but I do think there's not a lot that we can do to stop the Omicron wave now. Again, my view, and I've no real evidential basis to say this, but even a full lockdown might not have stopped the Omicron wave. You know, we've seen the countries, the countries that have done exceptionally well to date. So Australia, New Zealand, so many countries in Southeast Asia being the poster children. Omicron's taking off just there like it is here. So and they to be fair have lower booster coverage than we have in this country. We do stand out in this country. So the short answer to your relatively short question was, to an extent, we have to bear this.
Thank you. Councillor Grocott.
Thank you, Lord Mayor, and thank you, Greg and Anthony, for the update. It was really helpful and concise as always, and we do appreciate that. My question comes on the back of a local free newspaper which dropped through my door this morning with a very large headline from someone who is not a medical professional, who is talking about the case for vaccinating children having never been clear that children are at extremely low risk, and is calling for the JVCI to review whether or not children should be vaccinated. My concern is obviously where does this leave us, because people who may today be going out to get their children vaccinated may be looking at this article and wondering what to do. It's mentioned in there that the Chief Medical Officer said last September that the benefits of getting children vaccinated were marginal. So there is quite a case there for people not to engage in getting children vaccinated. So my question is, what would your position be, and what is the benefit of children receiving the vaccine or not, based on this information that is now certainly circulating around the north of Sheffield? Thank you.
As a jobbing clinician with a particular interest in this, I'll let Anthony go first, I think.
Okay, you can be one wingman on this, because you'll probably want to add something. Obviously, the JCVI look at these things all the time, continuously look at the developing evidence. So I'm sure if the case becomes evident that under 12s effectively need vaccination, the group that currently don't qualify for vaccination, that they would recommend that quickly. As you quite correctly say, the amount of serious illness in children generally, in under 18s in fact, but certainly in under 12s, is a very, very, very low number, an extremely low number. So the argument for vaccinating the under 12s would not be to protect them, it would be to protect other people around them in terms of preventing spread. Now that's not an impossible thing to do. It's an interesting ethical question, whether it's the right thing to do to vaccinate children with their parents' consent when the children are not going to benefit particularly. Some scare stories went around about harm from vaccinating children, particularly the teenagers. That was, statistically speaking, a scare story. The amount of real harm was virtually nil. I would say not at this point. I don't think the argument is made that the under 12 should be vaccinated. The numbers in Sheffield Children's Hospital, which of course serves a wider area than just Sheffield, are still very low. There are 10 children in Sheffield Children's Hospital with COVID and 3 with a post-COVID syndrome called PIMS. That's it across the whole regional area that Sheffield Children's Hospital serves, compared to the hundreds admitted every week to the Northern General as adults. So, and the amount of those children coming to harm is as close to zero as it's possible to get. So I don't think the case is made. I will defer to the Director of Public Health for what he wants to add on.
Thanks. I would broadly follow the recommendations of JCVI as and when they come. I understand JCVI are moving in that direction, but that's their call, not mine. I don't know when that will happen. A few additional observations. UK is behind almost all of the rest of the world, with almost certainly all the rest of the Western and developed world, with regards to the recommendation for vaccinating 12 to 17, and also the recommendation for vaccinating 5 to 11-year-olds. Most countries in the world have gone with it, actually. I think there are relatively few that are recommended against it. There is an increase in serious illness in children. That's a function of the numbers. Just the numbers of people affected will lead to an increase in illness. Nothing that's not to do with the intrinsic nature of the virus. It's just to do with numbers being affected. There is actually a benefit in terms of reduced transmission from being vaccinated. It doesn't prevent transmission, it reduces it. I can't remember the numbers offhand, but I think with Omicron, it reduces transmission by about 30 to 40%. And over a big cohort of population, that does make a difference. And obviously, the thing that swung it with regards to 12 to the older children was to reduce transmission, and that buys you more time in school. We've disrupted children's education enough, so anything we can do to buy more time in school would swing it. And there is a reduction in transmission. There's also obviously a reduction in serious illness, which is very, very rare, as we know. The basic question is, kids are going to get COVID. Unvaccinated kids are going to get COVID. It's almost inevitable. They're the last group that haven't been vaccinated en masse. So does the risk of illness, is it more or less than the risk of vaccination against illness, which reduces your chance of getting illness and certainly reduces your chance of serious illness should you become infected? My read of the evidence is that the risk of vaccination is way less than the risk of illness, and I would recommend, not my call to recommend, but I would recommend vaccinating younger children. But you can see Anthony and I have slightly different views, and it's important that people hear that there are differences in views and opinion out there. The one thing I will dwell on in terms of the risks from vaccination, myocarditis, which is inflammation around the heart, is the key risk that's been cited by lots. So it does happen. It's vanishingly rare, myocarditis following vaccination, vanishingly rare. Of that does happen, almost all mild, self-limiting, and almost all resolved. Myocarditis is 16 times more common from having had COVID than it is from vaccination against COVID, and obviously vaccination against COVID significantly reduces your chance of getting COVID. So my sense is that JCVI will recommend vaccinating 5 to 11-year-olds. I don't know when that will happen, but JCVI is behind the rest of the world in that respect. And for what it's worth, I would make the recommendation, but it's not my recommendation to make.
Thank you, Greg and Anthony. Councillor Argenzio, please. Would you ask your question? And can I please remind councillors to be quicker in asking the questions, then more people can get to us. Thank you.
Thank you, Lord Mayor. Thank you, Greg and Anthony, for your presentations. My question is about messaging and about balancing how infectious the Omicron variant is, but at the same time also supporting those businesses, in particular entertainment, theatres, cinema theatres, music venues, etc., that have really suffered for a very long time and don't have as much support as other businesses because they might be, disconnected from being able to apply for things. So how do we encourage people to support those businesses and at the same time ask them to be really careful, taking into account how messed up the messaging from central government is for a lack of a more polite way of putting it out there?
Thanks, Councillor Argenzio. So I'm not sure on the how, other than that it is finely balanced. There's probably a message that we should all take on the support your local businesses. We all know the Sheffield economy matters, and we all know that it's struggling. So if you were faced with the choice of going to the cinema in Sheffield or going to the cinema in another town, and I won't pick on another town, pick a Sheffield cinema, ditto a theatre, ditto a hospitality venue. All of them come with some risk. Maybe it then also depends on the who's going. Are they well vaccinated? What risk appetite do they have? We're seeing that people who are fully boosted are still able to be infected but have a mild illness. So I'm not sure that I could invent, and I'd probably be loath to try and invent now or sort of a route through that one, other than it's finely balanced. And social and economic harm that come from businesses not being able to pay their staff and kind of going under matters a lot. So I think that I'm increasingly of the view that we'll get to a stage where once we've got a fairly well vaccinated population, and we're kind of there now, notwithstanding the 100 or so thousand that haven't yet had dose 1 and dose 2, you get to a stage where you just have to make personal decisions about where you want to go and what you want to do. But I would, in all of that, I'd support the local business angle, because that bit does matter, and we can do that collectively. Sorry, a bit of a fudged answer, Councillor Argencio.
Thank you. Councillor Mick Rooney.
Oh, thank you, Lord Mayor. Thank you very much. I've got one of the questions is, and this is an opinion, I suppose. Do you think that we often chop and change the rules and regulations about what we can and cannot do too quickly? Given that it seems to me that sometimes we get 2 or 3 days or maybe a week of decent figures in terms of reduction, and then everybody goes daft and changes all the rules, and we eventually end up back where we started from. What are the signs of the Omicron? Because I was absolutely clear about what the signs were to look for with the other variants, but I'm not sure what they are for this one. The other is, do you think we're having a deep and long enough debate about the harm and cancellation of other operations and other treatments are doing to people, as opposed to, say, for cancer treatment or that? Do you think there's a proper debate being taken place about prioritising COVID? And my last one is, I had my second jab in April. In August, I caught COVID. I've had a booster since, but my fear is I don't know how long that booster is going to last. So are we talking potentially of having, boosters for everybody every 6 months or so? I just wondered what your opinions are on those. Thank you.
Thanks, Councillor Rooney. So in reverse order, the booster and frequency of further injections, we genuinely don't know. I think the likely worst case scenario would be an annual vaccination as per flu for those eligible for flu, probably given at the same time, just for operational ease. But no one actually knows how long immunity from vaccination against this strain or another future strain of COVID may last. So that's science that's developing fairly live and fairly rapidly, actually. So no one genuinely knows. On the question of displaced care, and are we giving enough emphasis and reason to debate that? No, is the short answer. One of the things that worries us all is the consequences of delayed and displaced care. That will have an impact for months and years to come, I suspect. Most obviously and visibly, look at elective waiting lists in hospitals up and down the country. This hospital is no different, but equally the consequences of care that hasn't been able to have been given in primary care will have an impact, and we'll have to work out the consequences of that fairly live over a period. On that one, it's worth dwelling on, and I may try and find it if I can and put it in the chat, the input that Chief Medical Officer did to, I think, the Health Select Committee when asked a question on displaced care. And to paraphrase, and I may get slightly wrong, his response was along the lines of, the NHS does what it does best. It prioritises urgent and pressing care that happens to be in front of it at that time. If we had neglected COVID, we didn't have any choice but to put all of our energy into the COVID response. If we had neglected COVID, the NHS and social care system would have been very, very, very overrun, as did happen in lots of countries up and down the world. And that has very immediate consequences. So yes, the displaced care and the delayed care matters, but there was really no option other than to focus our energy on the response to COVID at that particular time, and arguably still now. But it's not that it's not important, it is important, but you're right, we don't put enough time and energy into a reasoned debate about some of that stuff. On symptoms, I'll hand over to Dr. Gore, who is a jobbing clinician, so he'll be able to tell you a real live question. And on the frequency of rule changes, arguably, yeah, probably a little bit too frequently. I hope councillors will be satisfied that in Sheffield we've tried to stick to a sort of the core points and the core basics of how to prevent and or reduce transmission, rather than an ever-changing, ever-evolving set of rules, which are largely based on the core set of principles, because very few people have read page 674 of the guidance. The core principles have been pretty much constant throughout. So in Sheffield, we've tried to focus on the core principles and sort of cut to the basics all the time. We're not always successfully, I might add, and lots of people do want to know what it says on page 674 of the guidance, and the honest answer is I don't know. So we try to stick to the core principles, but yeah, we have arguably chopped and changed nationally a bit too often. If I hand over to Anthony to talk about what the symptoms actually look like in clinical practice, he'd do a better answer than me.
Yeah, and thanks, Greg. What we already knew with Delta, that it was moving away from those classical symptoms as described with COVID originally, you know, the loss of smell and the dry cough. We already knew there was more variation in symptoms. And then as we increasingly got a population that was double vaccinated or had natural immunity because they'd had it, like yourself, Councillor Rooney, and now with a boosted population, if individuals who are very heavily vaccinated or have got some immunity catch COVID, their symptoms are even more likely to be less than the described typical of COVID. And then with Omicron, we know even more so that it doesn't display those classical symptoms that we originally all got drilled into us right at the very beginning about loss of smell and dry cough and high fever. You might not get those, yeah? And I think that's a very important message. And I think that's one of the things that's perhaps has got through, that people is driving the high demand on PCR testing. But also, as a jobbing GP, I know lots of people ring the surgery every day and say they've had cough and a cold for a few days and they want to be seen. And I go, have you done a COVID test? And they go, no. Why not? How do we know if it's COVID otherwise? And that is still a big issue, that the messaging on that is not crystal clear, that those original classic symptoms as described, you might not get those now. It's increasingly more difficult to tell between a bad cold and cough and COVID in someone who's got some immunity, either because they've had it before or because they're well vaccinated. And it is an issue. And it's an infection control issue day to day in outpatient departments, in GP practices, on hospital wards, because the only way you can know for sure is a PCR test. On the other thing you mentioned, Councillor Rooney, the NHS has been very, very clear that it has to continue to prioritise important diagnostic testing, including for cancer and other serious illness, and they're not to be stopped anymore like they were in the first wave of COVID. And I think that's right. I think an awful lot of there will be an awful lot of suffering, if you like, for a number of years from all of the elective surgery that Greg referred to. An awful lot of orthopedic surgery will take years to catch up on. That's an awful lot of people who will be partially disabled or in pain, that will be in constant contact with their GP. So it will create an awful lot of unwellness, an awful lot of activity in the NHS, just having those long waiting lists again that we'd hope we'd never see again. But in terms of the more dramatic harm on cancer weights and things like that, with a lot of that has been partially recovered, and everyone's determined not to allow that to slip again. And certainly Sheffield is no worse than anyone else on that front. You know, in many cases, a lot better than some other areas in terms of cancer performance. But it has been affected by COVID, and it continues to be.
Thank you. Councillor Andy Sangar.
Thank you, Lord Mayor. Happy New Year, everybody. Thank you to Greg and Anthony. I'm on day 18 of my of Omicron, and for me it was very much 3 days of a cold like symptom. But I you know, because of my severe asthma, I reckon I've still got another 2 weeks before I could stand up in front of a class and teach, or you know, or go on stage as an actor, those sort of jobs. So I would still be disabled for several weeks. And I got Omicron 7 weeks after my booster. So I think my so I think my question really is about, I've got two questions. One is about the 22% of the 12 and overs who haven't yet been vaccinated. And we're not talking about the refuseniks. We're talking about the ones who have been hesitant. And Greg said, we're doing as well. We're doing better than the other core cities, but we've still got to keep pushing, because for people who are not vaccinated at all, particularly older people or people with underlying health issues, they can still get a very severe illness. So what more can we do in terms of keeping going with the vaccination program? So I've had a flu jab for 22 years. I'm fully expecting to have a COVID jab for the next every year for the next X number of years. I think that's just the only way we're going to get out of this. And I think the other thing to say, as somebody who's because all three of us in the house got it, and because my wife is in the NHS, we had access to PCR and lateral flow tests. And clearly, my son and wife were advised to take lateral flow tests on days 6 and 7 to allow them to go back to work on day 8, and they were still very positive on lateral flow tests on day 7, and even on day 9, all three of us were still positive, and yet the two of them were completely well. So I don't see how people can be saying that isolation should be moved down to 5 days, because if the lateral flow test is the test, then we were still positive on day 9, and I'm sure that applies to lots of people who had got over the illness. Thank you, Lord Mayor.
Thanks, Councillor Sangha. Again, I'll start and I'll let Anthony pick up. So in order, the as yet unvaccinated, as I say, it's hard to know what we could be doing that we aren't doing. Three broad areas. One is do we know who they are, and are we able to kind of identify them patient by patient, cohort by cohort? And yes is the answer to that one. Certainly the primary care networks have a pretty good handle on who they are, and have invited them frequently. Secondly, is it accessible? So you remember the very, very early phases of the vaccination programme, there was a giant mass vaccination centre at the arena, which is great if you live close to the arena, but it's not much use if you live in the depths of Fulwood and you'd need 3 buses to get there. So fairly quickly after that, primary care networks came on stream and provided much more locally accessible vaccination. After that, we then got into pop-up clinics in all sorts of places, in mosques and community centres, to a certain extent, and we'll go a little bit more down this path. On the bus, we have a COVID bus for Sheffield, and it roams around various parts of town, and we'll be vaccinating. So, making it as accessible, making it as accessible as possible has been a strategy and will continue to be a strategy. And the third one is openly and honestly talking to people where they have fears. People have legitimate fears, and just openly and honestly talking to people. The commonly occurring fears are, it can't be safe. It was developed so quickly. How can that be possible to be a safe vaccine? And there's a reasonable
Richard Dimwell's lecture.
And the second fear that I hear most frequently is that this is a vaccine that will affect my fertility. Wrong. There's zero evidence on that one. And just talking to people in groups or one-to-one in any way, shape and form. We've done a lot with faith and community leaders. I know clinicians up and down the city have done a huge amount talking to people in groups and one-to-one. That's the path that we'll take, and I think we'll continue to take. I do not, almost as a rule, engage with those who are anti-vax, because it creates publicity. People get more confused in the publicity, and that people will come to harm. There are people who are willfully spreading misinformation about vaccine and its impact. That has and will cost lives, and there will be no accountability for that, sadly. But I will not engage with that, because it's just a strategy I know from bitter experience that doesn't end well. The second question on the isolation period, I think I fully support the isolation period of 7 days with 2 negative lateral flow devices, aka the current policy. The evidence is pretty clear that 7 days plus negative test on day 6, negative test on day 7 is equivalent in terms of knock-on transmission to 10 days of isolation, then you're released on clink. from the clink, so to speak. I wouldn't go to 5 days. That would be a call that the Prime Minister will have to make based on the available evidence at the time. I would guess that CMO is providing that evidence probably right now, but until CMO has been into that space, it wouldn't be a space I'll go there. I'm not quite sure the science supports a 5-day isolation period.
Just on that, Councillor Sanger, you know, we know how infectious Omicron is, super infectious. It has high viral loads from the very beginning that potentially go on for a higher level for longer. It's infectious for longer as well as, you know, so it makes no sense to go to 5 days. You'll catch more people still being infectious when they go out. And in fact, the guidance for health and care workers is now that they potentially needs to isolate and only go out on day 15 if their lateral flow test remains positive. If it turns negative, of course, as we said, that they can go out, but then now in a position where they're potentially 14 days isolation if you work in health and care, because you may be meeting vulnerable people and people that you definitely don't want to spread it to. So your instinct is right, that would be a major worry.
Thank you. Councillor Milson, ask your question, please.
Thank you, Lord Mayor. Thank you. And thank you to Greg and Anthony for persisting and answering all the questions and for the presentation. My question is about delivery of third primary vaccine doses to at-risk cohort. And it's a subject that we touched on back in November, I think, at another briefing, and we identified a problem there that cohort weren't necessarily being identified swiftly and correctly, and it wasn't the same system as the first time around when the vaccines first were rolled out, and it wasn't the same system as when the at-risk groups were identified at the very start of COVID. So I'm asking, can we be confident now that those at greater risk have been identified for that third primary dose successfully? So I'm following up on what we discussed a couple of months ago. And can we be confident that those people will also be called for a booster at the right time, as their third primary dose will presumably still require a booster? At least that's what was being said last November. And so essentially, is there now a robust local system for identification and management of that at-risk cohort? Thank you.
Councillor Milson, when all that stuff gets announced, I can assure you from a jobbing GP's point of view, it's an absolute nightmare, because they do national searches of the coding in our records and come up with total nonsense. And then loads of people get told they're at risk and they need this third primary jab, and it's a complete surprise to them. And then, of course, they go, oh, well, we've got it wrong. So then they go and ask the hospital consultants to produce lists, which is a completely different list, which creates even more confusion, and so on and so on. I'm not sure that local is necessary. Well, they need to have a system that works everywhere. So I think that the idea that they can interrogate electronically the records for who's clinically vulnerable and contact them all direct is the correct way of doing it. They simply manage and conspire to get it wrong every time, and then we have to sort it out and mop it up and reassure people they don't need it, and so on and so on. So I'm hoping, because every time it happens they get feedback and get told what's wrong with their searches and everything like that, that actually the next time they try and identify the cohorts, it will be done better. Can I give you a cast iron guarantee? Right now.
Okay. It's now Councillor Stephen Aries.
Thank you, Lord Mayor. Thank you, Greg, and to Anthony for the presentation. I just wanted to return back to the impact on you know, within the usual annual scenario of winter pressures on hospital services. I just wondered, I mean, it has been said by Anthony, I think earlier on, that clearly normal hospital services are under additional pressure. I just wondered what measure we have to show just which way it's going. So my question was, what was the current ratio of COVID-related hospitalisation to non-COVID related hospitalizations. I'm just wondering where the trend is going. Are we are we coming out of that pressure, or is it worsening, or just wonder what the situation was?
Thanks, Councillor Aries. It's a high level and slightly worsening. I think if I had to simplify most from memory, the proportion of hospital beds with someone who has COVID in that bed is about 20%, there or thereabouts. Remember, some of those will be in hospital because of something else, and they all get tested when patients all get tested when they go into hospital. So some will be with COVID, but a significant proportion will have been hospitalized because of COVID. And that trend is only going to go up. We don't know for how long, but the hospitalization lags cases because you take a couple of days to become poorly, then you take a couple of days to get the test result. And the illness, probably the serious illness, and then the hospitalization lags the case rates by about a week to a fortnight or so. So I think that will get worse before it gets better, sadly. But already it's at a high and fairly unsustainable level. And once again, remember, it's not just hospitals. We're concerned about the totality of the NHS and social care system. The measurable bit is the unit that is the hospital bed. But as Anthony will say, primary care is exceptionally busy. It's just much harder to measure for all sorts of technical reasons. But I think we're not out of the woods by a long stretch.
Could I, sorry, Lord Mayor, could I just ask, how does that compare with the national trend? Is it about the same?
Slightly worse than national, but only just. Is probably about the same or so it's difficult to compare the national trend because we're all at different stages of the epidemic curve. London is ahead of us and is probably beginning to come out of it, and different parts of the country are at different stages, and obviously also is compounded by the level of bed availability does vary from place to place. There are more beds in Sheffield than per capita than there are in other parts of the country. So difficult to draw a definitive conclusion. But if I had to, I'd say that Sheffield is about average in this respect and many other respects.
Yeah, the only thing I'd add is that I'm not an expert on hospital bed management, but you can imagine if they've got multiple wards dedicated to people who are positive with COVID, and then they get a COVID positive case on a ward that was meant to be COVID negative, that effectively closes down that ward to new admissions for a while. And then they have to free up wards that should have been used for elective care and surgery for more medical cases. And this, to a degree, this happens every winter, but COVID just exacerbates that because you're trying to separate out all the time, and it just means your bed management and your efficiency and the number of free beds you have at any one time that you can actually use is always less than you want, and that's what causes backing up into A&E and hospital and ambulance queues, and then affects ambulance response times, and and that this is the sort of nightmare scenario of something that's so infectious. It has this knock-on effect down throughout the whole system. So it's not just about the beds, it's the knock-on effect throughout the entire system, both aftercare in social care, the front end in GP land, and everything in between.
Thank you. Councillor Little, you asked 2 questions on the chat. Do you want to ask both those questions now, please?
Yes, the first question is about the Northern General Hospital and the Royal Hallamshire having poor ventilation on their wards. Is this being addressed, or has it been addressed as an issue? And the other question is the availability in local pharmacists of rapid flow tests. I can't get them locally.
I think I can pick up both of those quickly, Councillor Little. Firstly, on ventilation of both of the 2 main sites, I don't know is the honest answer. I think all big sites are doing all they can with regard to ventilation, but remember there's a whole bunch of questions that are inherent to the building design in there. Where windows can be opened, they will be open. Where airflow can be found, can be achieved in certain ways, it will be being done. But some of it will be the inherent building design questions. And I don't know what more can and is being done. So I'll commit to providing you with a follow-up answer on that one. With regard to lateral flow device testing, the level of demand on lateral flow device testing in the run up to and over Christmas period was just unprecedented. Sheffield got to its critical reserve, and we were reserving what stock we held as a local authority for essential frontline services, blue light services, NHS social care, so that they could keep running for obvious and important reasons. That had a knock-on consequence on public availability of lateral flow device testing. I don't think that has quite eased yet, but I'm told that there are significant supplies being given to community pharmacies up and down the country, including Sheffield. Last I heard, which was yesterday, the general view, and I haven't got data to back up this view, is that the supply for both the online channel, people ordering lateral flow device tests online, and community pharmacies was significantly better than it has been. But again, I don't think it's quite resolved yet, and I think it's a little bit fragile. It's worth me saying, and I'll say on record, credits to all those who sorted out the logistics to meet the massively increased demand for lateral flow device tests, not just locally, but nationally. That's been a significant effort, but I don't think we're quite to the woods yet, but it's better than it was.
Thank you. Thank you, Greg.
Thank you. Councillor Maroof.
Thank you, Lord Mayor. This is a question not from me, but a question that gets put to me, which is, does being vaccinated mean you're immunized against catching COVID, or do you just get a milder form? I mean, this is a typical question that you get from people who don't actually want to get vaccinated. And my second question is the new Cyprus findings of Deltacron. Is that something that we need to be concerned about, or are we going to get various different variants coming along and we get frightened by each one of them that comes along? Thank you.
In reverse order, there was an excellent comment on Deltacron on the Science Media Centre yesterday. For those of you that don't know, Science Media Centre is one of the trade secrets, and where stories are in the press, I always look to see what Science Media Centre have said. But the view from Science Media Centre with regard to Deltacron is it was a lab error where samples have just become mixed in the lab somehow, rather than a brand new strain and a brand new variant. That said, there will be further mutations. You know, what are we on now? Omicron will mutate into something else. That's almost a biological certainty. Quite when, how, and what that will look like is anybody's guess. What we do when we run out of Greek alphabet letters to call them, I don't know. There's not that many Greek alphabet letters left. But it will mutate further. But Deltacron is almost certainly a lab error, from what I can understand. On the question of vaccination and immunity, the vaccine is hugely more effective than I had dared hope for a year ago by many orders of magnitude. I'd hoped it would be effective, but it's played out way more positively than I dared hope for. Way more effective than the flu vaccine is, actually, in terms of reducing severe illness. Until Omicron appeared, it was very effective, about 60% effective in terms of reducing transmission, the ability to acquire the virus, and somewhere in the order of 90% effective in terms of the ability to cause serious illness, most obviously measured by hospitalization, illness bad enough to require hospital treatment. For Omicron, it's been dented a little bit. So it's about 80 to 85% effective at reducing serious illness, hospitalization, and I think it's about 50%, maybe a bit less effective in terms of the ability to catch the virus. 50% are still odds I would take, actually, and played out over a big population. 50% reduction it matters and matters a lot. So, but it's not true to say that it's 100% effective against catching the virus and/or severe illness. No vaccine is, but this is an amazingly effective vaccine, all things considered. Hopefully that helps clarify.
Thank you, Greg. Thanks.
Thank you. Councillor Jones, would you like to ask your question, please?
Yes, thank you, Lord Mayor. One of the things I was wondering is, you were talking rightly about the impact of COVID on other treatments, things like cancer and such like. Are you currently aware of the number of vacancies there are within Sheffield for cancer clinicians and specialists? What is the strain on the system at the moment? And even if COVID wasn't an issue, do we feel that we've got a sufficient focus on this therapy going forward?
Go on, Anthony's hand.
Well, I was going to say,
up,
obviously, Sheffield is a cancer treatment centre, so it treats, for depending exactly on the exact tumour site, it treats patients from all over, either a sub-region just of South Yorkshire and Bassetlaw, or sometimes even for some cancers a much larger regional area depending on the cancer. So we can't claim them as being Sheffield's cancer doctors all the time, but obviously it's a full cancer service. It involves radiographers and radiologists and pathologists. It's a full cancer team. So actually it's much more nuanced than that. There are different gaps in different areas in different tumours. So they may be short of a specialist pathologist for thyroid. I'm not saying that's the case, by the way, it's an example, and a pathologist for cervical, but not short of any surgeons anywhere, So if you wanted a breakdown of that, we'd have to go to the Cancer Alliance for South Yorkshire and Bassetlaw and ask them for a sort of breakdown of where all the gaps are. In terms of what I know off the top of my head, our biggest shortage is in oncologists, but that's not a South Yorkshire issue or Sheffield issue. That's a national issue, that the major shortage area for cancer treatment is in oncology. That's known about, and there's obviously efforts being made to try and recruit and to train more oncologists, as you'd expect. I don't know if that fully answers your question.
Thank you. Councillor Diamond, would you like to ask your question, please?
Yeah, thank you, Greg and Anthony, for the presentation and all the answers to the questions. My question is about Omicron and whether it is less severe when in terms of illness compared to previous variants, even among unvaccinated people, or if there's evidence to show that. And secondly, do you think there is enough awareness among people of the pressures that the NHS is under currently, or do you think this has not got enough attention? Thank you.
Thanks, Councillor Diamond. So in order, the general consensus is that in those that are unvaccinated, i.e. have seen no vaccine, Omicron is about as severe as Delta was. So on average, and the reality is many people will have mild illness, and that's fine, and they're lucky, but significant numbers didn't have a mild illness. So the question is, do we want to play the chance? And the best chance of reducing severe illness is to be vaccinated, but milder isn't necessarily mild. All of these things are relative, and severe illness from Delta killed and hospitalized plenty. So the best route is still being vaccinated, and milder doesn't necessarily mean mild. And as Anthony said, getting the messaging right on this has been proved difficult, actually, because we all want to hear it's mild, and it is milder, but just the transmissibility turns into a game of numbers. There are significant numbers of people who've been made poorly. And then on the second question, mental block. Sorry, just briefly touch on the second question again. Sorry, I have mental block.
I just wondering if you thought there was enough awareness of the pressures that the NHS is under at the moment.
No, probably not is the answer. Certainly not with regard to pressure that's not in the hospital. The hospital is the bit of the NHS that gets all the media reporting. It's impossible to understate the pressure within primary care and other bits of the NHS and social care, to be honest. And we only experience it for real when it's something that touches us or the lives of one of our loved ones. And the reality is that won't be for a great many people of Sheffield. Therefore, many people say, oh, well, it's not that bad. It can't be as bad as all of that. But it's under significant and really quite exceptional strain, and has been for many months now. And again, staff burnout is an issue. It's a very, very, very real issue. NHS and social care have been at the front line of responding for as long as I have now, 2 years, and burnout is an issue, definitely. Anthony may add.
I just want to add that obviously a lot of the NHS pressures pre-existed COVID. COVID simply exacerbated them. We had shortages of GPs and issues with some practices being less resilient than others. Anyway, and we had issues with certain hospitals in the country with their performance and their waiting lists. Anyway, to a degree, that will always be the case. But COVID has exacerbated that. there's a tendency for the poorest areas socioeconomically and so on to receive the worst deal, and that therefore gets exacerbated. They're the areas of highest demand, they're the areas with the highest number of COVID cases, etc., etc., etc. So all of these things tend to snowball under pressure, and COVID has now provided, as Greg said, 2 years of extra pressure and people just being constantly on the treadmill. So where you've got services that are perhaps were already the least resilient, they are now the ones that are most at risk of falling over, whether that be a social care service or a charity or an individual GP practice in some cases.
Thank you. Councillor Iqbal, would you ask your question, please?
Thank you, Lord Mayor. And thank you for the presentation, Greg and Anthony. Two quick questions. One I put on the chat there was, and you've both touched upon it, deprived areas and obviously the correlation with BAME areas as well. My ward, for example, it was just not looking for the figures today, but it'd be useful to get the figures on vaccinations. And I remember on dose 1 and 2, we ran some really good campaigns locally, but on the booster, I've not really picked up anything. And if there's anything we can do to support the second vaccination, I mean, sorry, the first one, because you said there's still, it seems like 10% of the population isn't vaccinated. It'd be great if there's anything we can do to support that. The second one is picking very similar to what Councillor Angela said. And I'd like to take this opportunity to thank Councillor Jane Dunn for writing to government regarding schools. My daughter says to me that it's absolutely freezing in the classroom because we've got to keep the windows open for circulation. They're not allowed to wear their coats, and she's had a cold for the last 2 weeks. So it's brilliant that Councillor Dunn has written in. Is there anything more that we can do to support the plight of schools, and what Councillor Dunn has, she's written on our behalf? So if there's anything we can do to support that position, because as we've been told, it's just going to get colder. And, if it wasn't for having the lateral flow test on a regular basis, I'd have to keep her off school. But, she was saying some of her classmates are in a similar position, but I have no idea if they are taking these lateral flow tests every morning. So it could just be the common cold like I've got, or it could be the virus. Thank you. Thank you, Lord Mayor.
Thanks, Councillor Iqbal. It's hard to know what more we could be doing on the ventilation point. The purchase of 7,000 HEPA filters from government to put into schools with the poorest ventilation, as measured by CO2 monitoring. Welcome, no doubts about the fact it's welcome, but 7,000 filters across 20,000 schools, each of which will have many, many rooms in. The math don't quite help. There is more that we can do on ventilation. The cheap and easy option is open doors and windows, but in winter that's rather less attractive than it is in summer for all sorts of obvious reasons, as your daughter knows to her cost. Ventilation has made a difference, there's no two ways about that. Wearing face masks has made a difference, no two ways about that, and needs to be well-fitting, needs to be covering the nose, all of the stuff that we've said many times over. Schools, to be fair to them, I think schools broadly know what they're doing now, and they call my team less and less and less. Hard to know what else we could be doing. There is more that we can and will do to push further on vaccination of the 12+-year-olds. Children's Hospital are about to, it might actually be this week, it might be rolling now, doing a round of visiting all schools again to do the mop-up. That won't cover the 5 to 11s yet because we've not got to that cohort yet. It's tough to know what more we could be doing. And in all of this, the maintenance of education and the least disruption to education also matters, but there will be some of that just on account of the COVID rates as they are and the requirement to isolate. So and there's no easy answers on that one, sadly, and I wish there were. But there's not a simple answer to that one to make it go away in the school age children, sadly. So the upside is that, as Anthony has said, the number of children that are made significantly poorly, certainly poorly enough to be in hospital, is vanishingly rare, just not in the same space as it is in older adults.
And in the absence of a magic money tree in Sheffield, I think all we can do is follow Councillor Dunn and lobby national for for funding for proper antimicrobial filtration in every classroom nationally, and I think that should be the case.
Thank you. Councillor Phipps, can you ask your question, please?
Thank you, Lord Mayor, and thank you, Greg and Anthony, for answering the questions. I'm just wondering, because we've mentioned booster programs and rollouts a couple of times, and the potential of future ones has been mentioned. So do you think we need to be doing more as a country in vaccine solidarity, so helping other countries with first and second doses, instead of looking at the potential for future blanket booster rollouts? So this is following WHO's criticism that wealthy countries can't boost their way out of the pandemic, and that booster programs are likely to prolong the pandemic. Thanks.
Thanks, Councillor Phipps. Global politics. In short, yes. The more that we can do, as quickly as we can do, to vaccinate the world. I forget the numbers offhand, but the vast majority of people across the world have not yet seen dose 1 and dose 2, never mind on their third and potential talk of subsequent vaccines. It's worth me reiterating again that I had mixed views on whether, before we started the booster program, I had mixed views on whether or not it was the right thing to do to implement a booster program when significant parts of the world's population hadn't yet seen dose 1 and dose 2. The science very clearly supported the booster program, and the way in which we've done it has doubtless saved many lives and saved many people from hospitalization. But that it isn't to neglect the need to ensure that there is safe and sustainable supply of vaccine for the world, basically. There's lots that pharma companies could be doing with regard to patents, for instance, that would ease the production and manufacture of vaccine outside of a patented environment. And there's lots that the countries across the world can be doing to ensure their delivery system is as robust as ours happens to be, and ours is very, very robust. Difficult for me to make a either or straight choice, because I don't think it is an either or straight choice, and to do so would be a political thing for me to do, so I'd better steer clear of that.
One of my GP clinical director colleagues at the CCG has a catchphrase where he goes, "That's a both and I think this is a both and." I don't think it's mutually exclusive. I think, there are cohorts in this country that need a booster. As we've already discussed, we may need to start vaccinating 5 to 12-year-olds. That doesn't mean we can't have the political will nationally or or internationally even to go and vaccinate the rest of the world. And actually, that's actually, there's some self-interest in that. The more we vaccinate the rest of the world, the fewer new things post-Omicron, and the less chance that we run out of Greek letters.
Thank you. Can Councillor Davidson please ask his question?
Thank you, Lord Mayor. It's a question that perhaps is an annual one, but it's still an important one. And it's because of something that arose from what you were saying earlier. What is the death rate at the moment, or in the last 2 years with COVID, compared to that when we didn't have COVID? That's the first question.
Councillor Davidson, all up to date, about 1,500 people have lost their lives to COVID, where COVID is mentioned on the death certificate in some way, shape or form. That's over the course of the pandemic. So up till the end of last year, it was about 1,400. It's now on about 1,500. And that will likely be, well, I hope it will be, a fairly short-term issue. That has had a significant increase on the overall death rate, but that will probably be a fairly short term. And as I say, I don't think we will see that many deaths from Omicron, because those that are most vulnerable are now well vaccinated. So, but that 1,500 has definitely had an impact on the death rate. and has definitely had an impact on life expectancy, which is a big deal. That's sort of there's a dip in life expectancy seen in Sheffield and every other town in the country. That will likely be a 1, possibly 2-year thing. The bigger concern on life expectancy is that life expectancy improvements have now ground to a halt. And at some point, I'll finalise the annual DPH report. Now, will be one of the main headlines. So that's a long-term trend. That's not a COVID trend. That's a long-term trend. Just to give you some comparison, so 1,500 people over the course of the pandemic have lost their lives to COVID. About 1,000 people die every year because of smoking. This year, last year, next year, going down because smoking prevalence is going down, but smoking is the new smoking. And the smoking isn't mentioned on death certificates. It's lung cancer that's mentioned on death certificates, or stroke or heart attack, or the things that smoking sadly causes. But so the principal causes of death are the things that are fairly well trod, and they are fairly unchanging, but COVID has had an impact, definitely.
But if a person goes into hospital with, let's say, cancer, but then catches COVID, which is quite possible when they're in hospital, what would their death be listed as?
Maybe a question for Anthony, who'll assign more death certificates than I ever have. Anthony.
Yeah, no, not as many as I used to. If they were in for routine cancer treatment, even if it was effectively going to be terminal care eventually, it wasn't done with curative intent, then undoubtedly if they catch an infection, whatever it may be, in the hospital and then subsequently die of it, that infection will go down as 1A on the death certificate. If they were also seriously ill with another illness like cancer that contributed them to being weaker, for example, and more at risk of the infection, that may also appear on the death certificate under part 2 of the death certificate. But in that scenario, there is no doubt if it was COVID they contracted and COVID they died from in the hospital whilst undergoing cancer treatment, it should be 1A COVID-19 that is the main cause on the death certificate, and I believe that would be the case most of the time. As Greg's alluded to, this sort of surge in excess deaths due to COVID will disappear when you look at a longer time frame, because it primarily affected the elderly. So if you look at average deaths over a 5-year or 10-year period, it will disappear. But when you look at the 1 year or 2 year period, you can see those 1,500 extra deaths in the city really standing out in the way that Greg describes.
One thing is clear is that some people can be surrounded by people with COVID and not catch it. Is that due to genetics, or is it the lifestyle in which they live? You know, the food they eat, and so on.
Well, I was going to say I've had COVID in my house just before Christmas. My 15-year-old son caught it from his girlfriend, and nobody else came down with it. So his 12-year-old sister, who's only had 1 jab, didn't get it. His 17-year-old sister, who was just double jab, didn't get it, and both of his boosted parents didn't get it. So I think it may be that he had Delta, of course, which is slightly less transmittable, and we were just lucky, or in our particular cases, our immunity held up. And as Greg alluded to earlier, in terms of the efficacy of the vaccination, if you are vaccinated, you are less likely to get it. The chances are it will work. It's just not 100%. So it is just in those cases where someone has definitely been exposed to it, they're breathing in the same air in the same house and they don't get it, that's immunity, because we know that it's very, very infectious.
Okay, thank you.
So just to add, I think with Delta, the secondary transmission rate, i.e. if I get it, the transmission to others, it was about 30 to 40% of people in my immediate household will get it. With Omicron, it's about 60 to 70%, but that still means that 30 to 40% won't. Some of that will be immunity, but a lot of it will be just random chance. A lot of it will be other people in the household taking care and opening windows and using different towels in different rooms. A friend of mine had it just before Christmas. He was basically banished to the spare bedroom by his wife, and food was passed under the door, and all sorts of emergency measures. His wife didn't get it. His wife was a GP, and she didn't get it. So you can take care. and it's not guaranteed that everyone in the household will get it by taking care. It's harder with Omicron, but it's still possible.
Thank you. Councillor Little, this will be your third question. If you've got any more, can you ask them now?
Yes,
please?
this is the final one. Is that does the 100,000 people in Sheffield not vaccinated? Does this include 12 to 15-year-olds?
Yes, Councillor Little, easy answer. It includes everyone over 12, basically.
Thank you.
The group I'm most worried about are the 45, 50 plus. In terms of those who are most likely to be seriously impacted, I'm much more worried about a 47-year-old bloke with type 2 diabetes and high blood pressure than I am a very, very healthy 12-year-old, because it's to do with the impact of the virus and the impact of the vaccine on reducing serious illness. So, but the direct answer to the question is that the 100,000 does include everyone aged over 12.
Thank you.
Thank you. Well, there are no more questions in the chat, so I'm going to take this opportunity to thank everyone for attending this meeting. Thank Greg for attending the meeting, and Anthony, of course. It's been very useful information. So I hope that council members and members of the... Thank you for that. I hope that members of the council and members of the public observing the event found the briefing. Right, so I think someone in the group is pressing something. It's not us in the town hall. So I'll just move on to say thank you everyone for attending, and that concludes the business for today.
Thank you, Lord Mayor.
All right.
Thank you.